Hello, everyone. And I hope everyone is having a wonderful day wherever you are, East Coast, West Coast, they're in between. I'm Muriel Finkel from Amyloidosis Support Groups. And joining us today is Paula Schmitt, our Executive Director.
Hi, everyone.
And Bob Gibson, our Special Projects Director.
Good afternoon, everybody.
And Monica Fawzy Bryant. And I will let Monica introduce herself in just a few minutes. First, we have a few housekeeping rules. We will be recording this and it will be shown on our YouTube channel and on our website, amyloidosissupport.org, in just a few weeks, maybe less. Many of you have sent in questions and we really appreciated it. We forwarded them all to Monica. Some of them were time sensitive and Monica handled them right away. Some of them will be covered in generalities today on the program. If for some reason you have a specific question that you don't feel was approached today, or you have more specific questions after the event today, Paula will be putting up a link to Monica's website at Triage Cancer, where you can click that on and arrange to have a private meeting with someone from Triage Cancer. Don't let the name cancer fool you. This is for all diseases. Today it's for amyloidosis. Okay, if you have questions today, please don't type it in the chat. Everything that Paula will be posting to help you, or Monica will be posting to help you, will be put up in the chat section. If you have a question today, if one of the presentations generates a question for you, we will try and get to it. Just put it in the Q&A section. You can also post a question anonymously if that's how you choose to do it. We won't give out your name anyway. You needn't worry about that. Okay, if the Amyloidosis Research Consortium has a survey for patients and caregivers based on the cost of treating amyloidosis, and they would very much appreciate it if you would fill out the survey. We've put out the survey for them in the past. There's a separate one for patients and there's a separate one for caregivers. And Paula will post the link for their surveys in our chat section. So you can click those on, copy and paste them, whatever. And it would be very helpful to them that if you would fill that out, okay? And finally, as always, we have a survey at the end of our program today. These surveys are very important for us to help develop new programs for you. The program today was developed because of previous survey results we had. So we would appreciate anything that you can do to help us, and filling out the survey is really very helpful. So without further ado, because I know you didn't come to hear me, I now present Monica Fawzy Bryant. So Monica, are you there?
I am here. Thank you so much, Muriel, for that lovely introduction. And thank you to all of you for spending part of your Saturday with us to learn a little bit more about health insurance. I want to start off the day by telling you a little bit about myself and my organization, so that if after today you still have questions, you know where you can go to get them answered. I know it's hard to believe that after 2.5 hours, we might not cover everything, but we're really only going to scratch the surface. And so again, my name is Monica Bryant. I am a healthcare rights attorney. And so what that means is that I help individuals understand the laws related to accessing healthcare. And I do that through my nonprofit called Triage Cancer. And Triage Cancer is a national nonprofit that provides education on all of the practical and legal issues that can arise after a serious diagnosis like cancer. And as Muriel indicated, although our name is Triage Cancer and we do talk a lot about cancer, I would say 99% of the things that we talk about are applicable to all of us, even before somebody has a serious diagnosis, but certainly once there's a diagnosis, there needs to be other decisions made. And how can we possibly be expected to make educated decisions if we aren't given the tools to do so? So that's really what I hope today is going to do, is to give you some additional tools so that you can make the right decisions for you. If you are interested in learning more about some of these healthcare related legal issues, I just want to mention we have some free educational events that you are more than welcome to attend. Anybody is welcome. And one of them is our virtual conference on October 2nd. It's a full day event. You can pop in, learn about some additional topics, and please feel free to share this with others that you think might benefit. We also have shorter monthly webinars on a variety of issues. And two I want to just make sure to highlight is next month's on Medicare. So we're going to spend 90 minutes talking about nothing but Medicare. And then our October webinar where we're going to talk about a little bit more about health insurance. And then we have several handouts that we refer to as quick guides and checklists. And these are short, 1 to 4 page documents that can be downloaded off of our website for free. And they're really introductions to various topics. And you can see they run the gamut from health insurance to employment issues to disability insurance to estate planning. And I bring this up now because throughout today's presentation, you're going to see links to relevant quick guides. And I believe there's also going to be a link posted in the chat for a document that you can download today that has clickable links to a lot of the things that I'm going to talk about today. So you don't have to type in the whole link. Now, when we talk about healthcare related legal issues, what are those? Well, I've certainly mentioned health insurance and employment already, but it also comes down to access to clinical trials and estate planning, managing the financial aspect of a serious medical diagnosis, and certainly advocacy, which we're going to come back to at the end of the day. And we know that a lot of these topics are overwhelming and can be hard to know where to start. And so we created some animated videos on some of the most common topics. These are available in English and Spanish and closed captioning. And so I'll point you to places where if you want to sort of hear something again, just a nugget, and you don't want to commit to a whole hour or a whole day, you can watch one of these videos to get that information again. Now, we have a separate website called Cancer Finances, and this website was born out of a comment that we got, which was somebody who attended our educational event said, I wish I could just put you in my pocket and pull you out every time I had a question about one of these issues. And since we don't have that technology yet, we did what we thought was the next best thing, and we created this website that has topics on all of the things that can impact somebody's finances after a serious medical diagnosis. But what's unique about this particular site is it's built in a choose your own adventure format. So it will ask the user questions, and then based on the answers to the questions, it'll take them to targeted information. So if somebody tells me that they're on Medicare, it'll take them straight to the Medicare information and not bother with information about other types of health insurance. But even with our Choose Your Own Adventure website, we know that there are still some times when you just need a direct answer to your specific question. And in those situations, we do have the Legal and Financial Navigation Program. And this is where anybody, individuals who've been diagnosed, and I know it says cancer, but as we've talked about, not specific to cancer. I've talked to several folks that Muriel has sent my way in the last couple of weeks. Caregivers, healthcare professionals, employers sometimes call us to try to figure out how they can best support their employees. But basically all you need to do is fill out the form on our website and you'll get a link to schedule a 30-minute call with one of our staff. Now, we don't provide legal advice, we don't provide representation, but we can give answers and at least point you in the right direction. So all of that was really just an introduction to me saying to you all that I acknowledge that what I'm going to share with you today is going to feel like a lot and is likely going to be overwhelming. There's no way around it. Health insurance in this country is incredibly complicated, but I do just want to start off with the idea that this is not your last opportunity to get this information or to ask questions. So with that, let's talk about health insurance. As I mentioned, health insurance is often a puzzle wrapped in an enigma, and it is hard to figure out what your options are. Many of us never think about health insurance until we get our first jobs, and then there's an option placed in front of us and we take that option and we rarely look back. The problem is, to really understand health insurance, we have to essentially learn an entirely new language, but nobody's actually teaching that language. And so what I find is consumers that feel like they really have a good grasp on health insurance, it's often trial by fire. They learn it because they have to, because they're diagnosed with a serious medical illness and they have to figure out how to navigate it. We anecdotally know over the many years of doing this work that people don't understand even the basics when it comes to health insurance, but there have been many studies to back up that anecdotal evidence. And this one study showed us that only 4% of Americans could actually define the 4 most basic terms that are used in a health insurance policy. So if people don't even understand the basic terms, how can we possibly expect them to be able to be educated and savvy consumers of healthcare? We can't. So today, I'm going to start at the very beginning. And I recognize that for some of you, this is too basic, but I also from experience know that it's nice to have a refresher, and it's great to make sure we have the building blocks so that when we get to the more complicated stuff, we're all on the same page. So these are some of the most common terms related to costs of health insurance. And regardless of where you get your health insurance, these are terms that are going to be used. So we all pay a monthly premium just to have health insurance. And we are going to pay this whether we go to the doctor or not. It's very similar to having homeowners insurance or car insurance all year, but never filing a claim. But then there are some additional costs when you actually go and use your health insurance. And the first is your deductible. This is a fixed dollar amount that you pay each year before your health insurance company starts picking up their share of the costs. The deductible is going to vary plan to plan. You could have a $0 deductible, you could have a $5,000 deductible, you could have a $10,000 deductible, but it's what you have to pay out of pocket before your insurance picks up their share. Their share is referred to as cost share or coinsurance. You're literally sharing the cost here, and it's presented as a percent. So you could have a plan that has an 80-20 coinsurance. That means once you've met your deductible, the insurance company starts picking up 80% of your healthcare costs, and you're responsible for 20%. Many plans have an additional payment called a copayment. And this is something that you're going to pay each time you get care. This again is a fixed dollar amount, and it's going to vary plan to plan and often service to service. For example, many plans have a copayment of $25 to go see the doctor, $35 to see a specialist, $250 to go to the ER. So not only do you pay it each time you get care, but it's going to depend on what service you're getting. Now, perhaps one of the most important things we can all understand about our policies is if it has an out-of-pocket maximum, what is that out-of-pocket maximum? Well, generally speaking, the out-of-pocket maximum is the most that you're going to pay out of pocket for your medical care per year. The way that you get to the out-of-pocket maximum is a math problem. Now, depending on where you get your insurance, the math problem could look a little different, but a general math problem is you add up everything you pay towards your deductible, everything you pay in co-payments, and everything you pay in coinsurance. And that's how you get to your out-of-pocket maximum. So it's everything you pay out of pocket except those monthly premiums. Now, like with many things, the devil's in the details here. So most insurance companies will only count payments made towards in-network providers towards your out-of-pocket maximum. So if you go out of network, they're not going to count that. And then some employer plans may have a slightly different formula for how they calculate the out-of-pocket maximum. For example, they might say, we aren't going to take into consideration your deductible. So it is important to look at your specific policy, but I want to give you, again, a very general example of how this works in practice. Meet Dan. Dan has a policy with a $2,000 deductible. It's an 80-20 coinsurance, and he has an $8,000 out-of-pocket maximum. Now, Dan hasn't used any medical services for the year, but then he gets in an accident, and he ends up spending a week in the hospital. and the total bill is $102,000. So what does Dan have to pay? Well, the very first thing we always pay is that deductible. We subtract that from the total bill, which leaves $100,000. He has a co-insurance of 20%. So his plan pays 80%, he pays 20%. 20% of $100,000 is $20,000. But what if that $20,000 does he actually have to pay? Here, he only has to pay another $6,000 because he's already paid $2,000 towards his deductible, and his out-of-pocket maximum is $8,000. Now that he's reached the $8,000, the health insurance company pays 100% of the healthcare costs moving forward. So I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start looking at the alternatives of what he would have to pay without the out-of-pocket maximum, which would have been $22,000, or certainly what he would have to pay without health insurance, so that $8,000 starts to feel a little bit more reasonable. And it's also really useful for us as consumers because we can actually start to plan around a worst case scenario. So I would actually, and I failed to do this originally, so I apologize, but I would actually, Bob, if you could launch the first poll and we could just get a sense of how everybody feels at this point about how their understanding of health insurance. Well, I'm certainly impressed that 14% of you feel like you are experts. I almost wish I had asked you this prior to that explanation and then after to see if things have changed. But certainly these are the basics that I hope everybody becomes comfortable with. And if you want to hear any of what I just talked about up until this point, so the terms and this example, you can see that in one of our animated videos on health insurance basics. And again, that's available for viewing on our website at triagecancer.org. Now, I've already said this term several times because it is key to how our health insurance system works. Most insurance policies have a network of providers that they contract with. Now, those providers could be doctors, they could be labs, they could be pharmacies, they could be hospitals. And by entering into the contract with the insurance company, the providers are agreeing to accept a specific amount of money for certain services. That specific amount of money is referred to as the allowed amount or the contract amount. Now, one of the reasons that I think health insurance is so complicated is that there are often multiple terms for exactly the same thing. And here's another example of that. So when we think about finding the right health insurance policy for us, we have to be thinking about the providers we want to be seeing and the networks of the insurance companies. And so we're going to come back to that in part 2 on picking a plan. Some other terms I just wanted to talk about because I know it is very relevant for this community are terms around prescription drugs. So many insurance companies will have a list of drugs that they will cover, and that list of drugs is called a formulary. Typically, formularies are broken up into different tiers or levels, and depending on where a particular drug falls in that company's formulary, the insurance company is going to cover it at a different rate. And us as consumers are going to have to pay a different rate. So for example, if you are taking a generic medication that is in your company's tier 1 of their formulary, maybe you're going to pay a $5 copayment every time you go and pick up that prescription. Or maybe instead there isn't a generic for the drug that you're taking and it is, a brand name drug. Well, maybe now instead of paying $5, you're going to have to pay $100 because it's in tier 3. Or maybe it's a newer drug, it's a specialty drug, And that's actually going to be listed in tier 4. And if it's listed in tier 4, instead of paying a dollar figure co-payment, now you're paying a co-insurance, which is a percentage. So you can imagine how that could be a significant difference based on how expensive a particular drug is to you. And so understanding where the drugs that you are taking or you are being prescribed fall in your insurance company's formulary can be incredibly beneficial. And we're going to talk about how to deal with some of these out-of-pocket costs if you do have a drug that falls into tier 4 or 5, depending on your formulary in a little bit. Now, some plans require something called step therapy in their prescription drug coverage. And basically what that means is it requires us as consumers to start with a less expensive drug and then show some sort of adverse reaction, like maybe you're allergic to it, for example, in order to get to step up to a more expensive drug. So one of the challenges with that is that it does take some of the control out of the providers who might not want you on drug A. They want you just to start with drug B. So what do you do in that type of situation? Well, there are opportunities for people to appeal that decision. And that's definitely something we're going to talk quite a bit about today. So it's not the last time you're going to hear me say that. But I wanted to talk about these terms before we get into the types of insurance, because it really is going to be quite relevant. Now, some other terms that you might hear thrown around relate to how health care is paid for in this country. And there are two main types of healthcare payment systems in this country. So the first is called fee for service. So fee for service is where services are unbundled and the providers will provide services to you, and they will charge you a certain amount for those services. Original Medicare is a great example of fee for service. The other type of payment system is called a managed care payment system. And this is where services are bundled under one managed care umbrella. And there are some limits as to the providers that you can see and the type of coverage that they're going to provide. And in exchange, the consumer pays less for those services. Medicare Advantage plans are a great example of managed care plans. So within managed care, there are multiple options. And these are 3 of the most common types of managed care plans. So starting on the left, we have health maintenance organizations, or HMOs. These are managed care plans that have a smaller network of providers. Many times they're within only one hospital system, and sometimes they're even housed all in the same building. HMOs typically require that someone starts with their primary care physician, and if the primary care physician can't solve whatever issue that person is having, then that primary care physician will refer the patient out to a specialist. But that primary care physician is the gatekeeper to all the care. So with HMOs, there's less choice in providers. There's a few more hoops that you have to jump through. Well, in exchange, you're going to pay less. Going all the way over to the right, you have a preferred provider organization, or a PPO. These are going to have the largest networks of providers, typically across multiple hospital systems. So if you want to see a dermatologist at one hospital system and an endocrinologist at another, you can do that. Typically with PPOs, there's going to be some out-of-network coverage. So they're not going to cover you at as high of a rate if you go out of network, but they're going to cover something. With PPOs, you don't have to start at a primary care physician. You can go straight to the specialist if you want to. Well, guess what? In exchange for more choice, more flexibility, more protection, you're going to pay more. And then EPOs in the middle are sort of a hybrid of the two. They're going to have a larger network of providers than with an HMO, but there's going to be no out-of-network coverage. So you have to stay within that network. you don't typically have to start with a primary care physician. So you have a little bit more choice than with HMOs, but not as much as with PPOs. So you're going to pay somewhere in between. So this is typically where people will say, well, which is better? And the answer is always, it depends. It depends on what's available to you where you live. It depends on what your needs are. So if somebody rarely goes to the doctor, annual checkup, doesn't really have any medical issues, doesn't really like to travel, just needs a doctor for the just in cases, maybe an HMO is a great option. For someone with a serious medical condition or multiple serious medical conditions, who, as I mentioned, want to go to a bunch of different specialists or need to across different hospital systems, maybe a PPO is better for them. So there is no one size fits all to anything that I'm going to talk about today, and this is really the first example of that. Now, in the United States, there are three main places that we get health insurance. The largest group of Americans get their health insurance from an employer. The next largest group of Americans get their insurance through the government, primarily through Medicare, Medicaid, and military plans. And then the smallest number of Americans go directly to a health insurance company to get their health insurance. But regardless of where you get your health insurance on our triangle of coverage, all of the terms that I've just talked about apply. So with that, I'm going to start getting into some places where we actually get our health insurance, some specifics about it. I mentioned that the largest number of Americans get their health insurance through an employer. So it begs the question, what happens if we have to stop working? Or if some other change happens in our life that impacts our employer-sponsored health insurance? COBRA is the federal law that allows eligible employees to keep the exact same health insurance policy when they would normally lose it. I say eligible employees because COBRA only applies to employers with 20 or more employees and local and state governments. The major benefit to COBRA is it's the exact same plan. Same coverage, same network, same everything. Anything you've already paid into your plan for the year keeps going. Nothing changes except who pays for that monthly premium. Many times with employer coverage, as I'm sure you know, the employee pays a portion and then the employer pays a portion of that monthly premium. Well, with COBRA, now it's the employee paying 100% of the premium, plus sometimes a 2% administrative fee. So it can be very, very expensive for the premium to elect COBRA. That doesn't mean that we should discount it. The length of time that we're allowed to keep our COBRA coverage is going to depend on the qualifying event. So if you have left your job, lost your job, or even gone from full-time to part-time, and your employer doesn't offer benefits to part-time employees, you will get COBRA for up to 18 months. If instead you are getting a divorce and it's your spouse's employer plan, well, you can keep the exact same plan that you had for up to 36 months. Or if instead maybe the employee decides to go on Medicare and you're not old enough for Medicare yet, well, you can get COBRA for up to 36 months. I mentioned that COBRA is only applicable to employers with 20 or more employees. So what do you do if you work for a smaller business? Well, in that case, you would want to look to see what your state COBRA law says. Now, the details definitely vary state to state. This is just some very basic information about the states with the states with COBRA laws and the amount of time that you're going to keep that COBRA. But if you want more specifics about what is available in your state, on triagecancer.org, we have charts of state laws that list all of this and then have clickable links to more information. So a lot of times people will call and say, I don't want COBRA, it's too expensive. And then I start asking some other questions, and sometimes it actually turns out that COBRA is the more affordable option. Or even if it's not necessarily more affordable, it's still the better option. And that's for a couple of reasons. The first is maybe you're getting better coverage through the employer than you would, let's say, on the marketplace. Maybe it's that no other plans cover the doctors that you want to go see. Or maybe you see doctors out of your state and your employer plan does offer coverage across state lines. Those are all reasons why you might want to pay a little bit more for the COBRA instead of starting over. The other piece that people tend to forget is based on where you are in the year, you may have already met your deductible and even your out-of-pocket maximum in your employer plan. And in those cases, it may actually cost you less to pay the high monthly COBRA premiums, but know that that's all you're going to pay for your medical care for the rest of the year. And so while we recognize that the sticker shock can be real with COBRA premiums, it sometimes is still the more prudent option. So moving on to our next largest group of individuals, which are people who get their insurance through the government. One of the programs that I mentioned is Medicaid. Prior to January 1st of 2014, individuals could only access Medicaid if they had low incomes, low resource levels, and resources are things like savings accounts or retirement accounts or life insurance policies or multiple vehicles. Those are all resources. So low income level, low resource level, and be able to walk through one of these 4 doors. Now, many people with serious medical illnesses would try to walk through this door on the left, but there were some problems with it. The first problem was for someone who may have been building up savings or retirement while they were working, they get hit with a serious medical illness and now they can't work anymore. They would literally have to spend everything before they could access these programs, and it would leave them in financial ruin. The other problem was this program, which is called the Age Blind Disabled Program. I did not name it. I recognize it's a terrible name. This program uses the highest standard of disability from the Social Security Administration. And so it was incredibly challenging to walk through this door for many people with serious medical conditions. When the Patient Protection and Affordable Care Act was passed, also known as ACA or Obamacare, the ACA created a 5th door into the Medicaid program. And this door was just based on income. So there was no asset or resource test, right? You could still have a savings account or a retirement account, and you didn't have to show a severe disability. It was just based on how much are you earning. And if you were earning at or below 138% of the federal poverty level, and I've given you the numbers here, what that means for this year, you could access the Medicaid program. So all those 4 original doors still exist, and they still have the resource test, and you still have to be able to walk through one of those doors. But this added a new entry point. This 5th door was supposed to exist in all 50 states. However, the Supreme Court got their hands on the ACA, and in their decision, they essentially made it voluntary for states to expand their programs. And I will tell you, this is the slide that probably changes most frequently, because as there are elections and voter propositions and changes in states, we see states move back and forth between these 2 columns. But right now, we have 38 states and DC who have expanded their Medicaid programs and 12 who have not. The people in the right-hand column, or excuse me, the states in the right-hand column represent about 3 to 5 million people who would have had access to healthcare who currently don't because their states didn't expand. You also see all these crazy footnotes, which you certainly don't need to read, but they are there to illustrate how this was not a one and done solution. These are all states that decided to expand their programs after the initial expansion period. So this is absolutely a place where we're still seeing changes. Now, with Medicaid, it is a federal program, but it is administered by the states. So there are a lot of differences with respect to what Medicaid programs in different states will or will not cover. So I do know I got some questions about specific to Medicaid that I certainly can't answer unless I know more information specifically about where you are. So if you have those questions, please feel free to fill out that form on the Triage Cancer website so that we can spend a little bit of time chatting and get you a specific answer. So that's Medicaid. Medicare is the other federal program for individuals who are over the age of 65 or who have been receiving Social Security Disability Insurance, SSDI, for 2 or more years. Also, individuals who have end-stage renal disease or ALS can also access Medicare. I'm not going to lie to you, Medicare is a lot. It's complicated, it's confusing, there's so many misconceptions. So we're gonna spend a little bit of time here. Even if you aren't currently on Medicare, please listen up because chances are you're gonna have to make some of these decisions in the next X number of years. One of the reasons that Medicare is so confusing is that it's not just one thing, but Medicare is actually broken into 4 different parts. Medicare Part A is your hospital insurance. This is going to cover hospital stays, some skilled nursing, inpatient care. If you have worked and paid into the system, you will likely get Part A premium free, which means you don't have to pay a monthly premium to have Part A. But as you can see, there are some other out-of-pocket costs associated with Part A, particularly if you have a lengthy inpatient stay. Typically what happens is once somebody turns 65, even if they are still working, will get Part A automatically. They will often also get Part B. Now, Part B is your medical insurance. Part B is what covers most of what people think about as healthcare. Doctor services, immunizations, outpatient care, scans, tests, durable medical equipment, all of that's covered under Part B. Even if you've worked and paid into the system, there is a monthly premium for Part B. This year, that is $148.50 for most people. If you have a particularly high income, that could be more, but for most people, that's the monthly premium. There's also an annual deductible. This year it's $203, and there is a cost share. Medicare Part B cost share is 80-20. So what that means is you start receiving services, you pay your $203 of your deductible, then Medicare starts picking up 80%, and you're responsible for 20%. There is no out-of-pocket maximum with Part B, which means you pay 20% all year. We're going to talk about how to deal with that, but I just want to be very, very clear because there was a lot of questions about that as well. There is no out-of-pocket maximum with Part B. When we talk about Part A and Part B together, that is what is known as original Medicare, because it's all that existed when Medicare was signed into law. Original Medicare is fee for service, which, if you remember, means you can go to any provider around the country that accepts Medicare and receive services. Many times, people, as I mentioned, when they turn 65, will get Part A and Part B automatically. They'll look at it and they'll say, well, wait a minute, I don't want to pay for Part B. I have Part A. Why do I need Part B? They decline Part B. Then they go to use their medical services and they find out it's Part B that covers everything. If you don't have any other type of coverage, like through a job, and you decline Part B, you may actually have to pay a penalty later. So before you go declining anything, make sure you completely understand what you're doing and that you have other type of coverage. All right. Part A, hospital insurance. Part B, medical insurance. Part D is prescription drugs. Part D plans are sold by private insurance companies. So Blue Cross Blue Shield, Humana, Aetna. You may even have one like that's like an AARP sold by Cigna. I'm making all of this up. But the point is, it's a private insurance company that names you're probably familiar with. The costs for Part D are going to depend on the policy that you choose. And as you can see, there's a pretty wide range of what those monthly premiums could be, from $5 to $205. With Part D, there is an annual deductible that cannot be more than $445. It could be less, but that's the ceiling. And then once you've met that deductible, there's some co-payments, which we're going to talk about in just a minute. When Part D was passed, it was passed with a gap in coverage. And that gap in coverage was named the donut hole. Now, typically when we're in person, I say the donut hole, I get a lot of nodding heads. And then I ask people, how many of you actually understand the donut hole? And since I can't see a show of hands, I'm going to ask Bob to launch the poll. And we're going to get a sense of how many people feel like they really understand the donut hole in prescription drug coverage. So Bob, if you could launch that poll for me, that'd be great. Thank you. Well, thank you for that. I am not going to lie. When I first started doing this, I definitely was in that a donut what? So prescription drug coverage in Part D is complicated. The donut hole was basically where individuals would have certain amount of coverage by Medicare for their prescription drugs until their out-of-pocket costs reached a certain amount of money. And then at that point, Medicare wouldn't pay anything until they got to the next threshold, and then Medicare would kick in again. So there was this period of time during the year, particularly for people who had expensive drug costs, where they had no help. And so it was literally a hole in coverage. Now, thankfully, the ACA addressed the donut hole by closing that gap little by little over several years. And last year was the first year where we didn't have a gap in coverage at all. And so here is what prescription drug coverage looks like in Part D this year. First, you have to pay your deductible, which can't be more than $445. So you pay that out of pocket completely on your own. Then you enter what's called the initial coverage phase. And at this time, you're responsible for 25% of your drug costs. Medicare covers 75% until the total out-of-pocket costs that you have paid for reach $6,550. At that point, you enter what's called the catastrophic coverage phase, where you're going to be responsible for 5% of your drug costs, or a nominal dollar figure based on what we're talking about, whichever is more. When we are talking about things like cancer drugs and drugs for amyloidosis, almost always you're going to pay the 5%. Well, 5% of a lot could be a lot. And here's another problem. There's no out-of-pocket maximum for Part D coverage. So you will continue to pay 5% for the entire year. Talk about it more. So A is hospital insurance, B is medical insurance, D is prescription drug coverage. You could potentially have 3 different premiums, 3 different deductibles, 3 different cost shares. It is complicated and it's a lot to keep track of and it's a lot to make sense of. So an alternative was created in Part C. Part C plans are also known as Medicare Advantage plans. And these are sold by private insurance companies and they are managed care plans. So they're going to operate very similarly to employer-sponsored plans or plans you would buy in the marketplace. You're going to have PPOs and HMOs. Most of them are HMOs. So all your care is bundled in this one plan. And the advantages are one premium, typically, one deductible, and very clear co-insurances. All Advantage plans have to include and cover the services you would normally get under Part A and Part B. And about 90% of them also include prescription drug coverage, so your Part D services. Many of them also include other types of services like gym memberships, and some even have things like carpet cleaning, for people who have bad allergies. And so there are some other benefits to getting an Advantage plan. Because these are sold by private insurance companies, the costs are going to vary just like other types of private insurance. One of the challenges with Advantage plans is in their marketing. So in the fall, you will start to see, probably next month, commercials about get your premium-free Advantage plan from X, Y, and Z insurance company. And it sounds really great. Like, wait a minute, why would I pay for Part B and Part D? I can get it free over here. But it's a little bit misleading because Advantage plans are going to cost you at least what you would pay for your Part B coverage. It's just that they don't cost you anything above and beyond that. And they may give you additional services. One of the major benefits to Advantage plans is that they do have an out-of-pocket maximum. So if you remember, Part B has that 80-20 co-insurance and no out-of-pocket maximum. Advantage plans have an out-of-pocket maximum. And that out-of-pocket maximum for this year cannot be more than $7,550. So if someone, actually I should step back for a second. With Part C plans, because they're managed care, they're going to have that network of providers that I was talking about. So whereas original Medicare is fee-for-service, you can go to any provider around the country, Medicare Advantage plans are going to have that smaller network of providers. So for people who are sort of vacillating and they like the out-of-pocket maximum, but they want to see a variety of providers, how can they possibly protect themselves? Well, if they want to go the original Medicare route, one of the ways to protect yourself from the out-of-pocket costs is by purchasing something called a Medigap plan. And these are additional insurance policies that you can purchase. They're sometimes referred to as supplemental plans because they supplement the coverage that you're getting in original Medicare. And they basically help to pay the out-of-pocket costs in Part A and Part B. So, assuming you have A and B and you've picked up a Medigap plan, the way that it works is you go to a provider bills Medicare, you pay your deductible, then Medicare pays their 80%, and then the Medigap plan pays the 20%, depending on which plan you have. Medigap plans are identified by letters A through N, not to be confused with Medicare parts A through D. I don't know why we couldn't come up with any other naming system, but here we are. And the number of people that will call and say, I have Medicare Part F, and not really understand what it is that they've actually purchased, it happens all the time. And I certainly don't blame people for it. This is incredibly complicated. But every Medigap plan of a particular letter has to cover the same rates. So all Plan Fs are going to cover the same. All Plan Gs are going to cover the same. It used to be that Plans C and F were the most comprehensive, and I guess they still are. But as of 2020, for anybody who's newly eligible into Medicare, they are not allowed to buy Plan C and F anymore. So if you've had Plan C and F, you get to keep it. But if you're new into Medicare, those aren't options anymore. So the next highest level of coverage is a Plan G. And the major difference is that C and F cover that deductible for Part B, whereas G doesn't. But what I think the most important thing that G does is that it covers the 20% Part B coinsurance. Usually people will say to me, wait a minute, you want me to pay for Part B, pay for Part D, and buy this other Medigap insurance? Like, why? Why would I buy this other thing? And I want to just go through an example to show you how it can be helpful. Meet Jimmy. Jimmy's almost 65. He lives in California and he's figuring out what his Medicare options are. He's about to start chemo that's going to last for a year, or an infusion. He's heard that his IV infusion is covered by Medicare Part B. Part B has the 80-20 cost share. His drug costs are going to be $10,000 a month. He doesn't want an Advantage plan because he spends part of the year in Florida, and so he wants to be able to see doctors both in California and Florida. But he's trying to figure out what his options are for the lowest out-of-pocket costs. So Part 1 is original Medicare. He's going to pay that monthly premium for Part B, so $148.50 times 12. So his premiums for the year are going to be $1,782. He has to pay his Part B deductible, which is $203. And then he has to pay that Part B cost share just for his infusion, which is going to be $10,000. So we're not talking about any of the other care that he's going to need. So just for his infusion, he's going to pay $24,000 in coinsurance or cost share. So the total that he's going to pay out of pocket just for Part B is $25,985 with original Medicare. But now let's look at original Medicare with a Medigap Plan G. We're just estimating that his Plan G is going to cost about $300 a month. It really will depend on where you live as to what it's going to cost. So we're just guessing there. So the Part B premium is the same. The Part B deductible is the same. He now also has to pay the Medigap premium for the year. So 300 times 12, which is $3,600. But that Plan G now picks up the 20% cost share. So for option number 2, with the additional insurance, his total Part B costs are going to be $5,585. So he saves $20,000 by purchasing this additional policy. So it can feel a little like sticker shock to think about, I'm going to buy something else. But when you start thinking about the costs and how to protect yourself from the out-of-pocket costs, these Medigap plans or supplemental plans can be incredibly beneficial. Now, the details. There are certain times in your life when Medigap plans are considered guaranteed issue, which means that you can purchase a Medigap plan and they cannot charge you more than the next guy based on your medical condition. That is when you turn 65 or when you have a special enrollment period into Medicare. So for example, if you've worked past the age of 65 and had insurance through your job, you don't have to pick up Medicare right away, but when you stop working, you get a special enrollment to pick up Medicaid and you can pick up a Medigap plan at the same time. Now, every single year, you can also make changes between which Medigap plan you have, but there are some differences and some challenges with that. Couple of things I want to note here too. If you are receiving Medicare because you're under the age of 65, but on SSDI, there are these states where it may be very challenging for you to purchase a Medigap policy. So keep in mind that if you live in one of these states, that might be an issue. I'm not saying you can't buy one. It's just that there's no requirement to issue one. So it may not be as easy as it would be for someone who's over the age of 65. For someone who is potentially sitting there thinking, well, great, I'm past my initial enrollment period of 65 and I didn't know this and I didn't buy a Medigap plan, like what are my options now? You could still potentially pick up a Medigap plan in open enrollment. They could put you through something called medical underwriting, which means that they're going to look at your medical history to decide how much they're going to charge you, and they might charge you more. They may also impose something called a pre-existing condition exclusion period. And that means that for 6 months, the Medigap plan isn't going to cover anything related to your pre-existing condition. Some people will hear that and think, well, what's the point? Why would I buy an insurance policy if it's not going to cover anything that I need it to cover? So let's look at Jimmy, assuming that he had a 6-month pre-existing condition exclusion period. So again, here is his option 1 that we talked about last time. It's $25,985 with no Medigap. Option 2 is picking up the Medigap plan, but he has a pre-existing condition exclusion period. So after 6 months, the Medigap plan will start to pick up 20%, and his total costs then are $17,585. So it's definitely not as good as if it picks up the whole year, but there's still a pretty significant $8,000-ish cost savings. And don't forget, he now has this Medigap plan moving forward for the rest of his life if he continues to pay for it. It also will cover 20% of other types of medical care that he might need. So the message here really is, if you didn't pick up a Medigap plan and you're regretting it now, but you don't know what to do about that exclusion period, try doing this math and you might find out that even without, even with the 6-month exclusion period, it's still actually more financially savvy for you to pick it up. Also, I got lots of questions about people wanting to see providers in different states. And this is the way in Medicare to be able to do that, because he has original Medicare so that he can see providers wherever he wants. And the Medigap plan picks up the 20%. So for those of you who asked that question, this is the way to do it. It's not all good news though, because there are a whole host of things that Medigap doesn't cover. And the short answer is Medigap doesn't cover anything that Medicare A and B doesn't cover. So prescription drugs that are covered by Part D are not going to be covered by your Medigap plan. That was a large number of questions that I got for people trying to figure out which supplemental plans do they buy or Medigap plans do they buy to help them deal with the Part D out-of-pocket costs. And the answer is there isn't one, because Medigap doesn't cover out-of-pocket costs associated with Part D. Okay, so to summarize, when you're trying to figure out what your Medicare options are, you essentially have 2 lanes that you get to drive in. The first is original Medicare, where you pick up Part A for your hospital insurance, Part B for your medical insurance. You decide if you want prescription drug coverage, which I hope the answer is yes, and you purchase a Part D plan from a private insurance company. Then you decide if you want to purchase an additional insurance policy, and you pick up a Medigap plan to help protect you from the out-of-pocket costs in A and B. Lane 1. Lane 2 is purchasing a Medicare Advantage plan from a private insurance company, managed care plan where your A and B services are going to be bundled. If the Advantage plan that you choose doesn't have prescription drug coverage included, then you can pick up a standalone Part D plan. But that is where the analysis ends in lane 2. And the reason for that is because lane 2 comes with the out-of-pocket maximum. So, which is better? It depends. It absolutely depends. There are pros and cons to both lanes. One of the major benefits, of course, is that out-of-pocket maximum with an Advantage plan. But the downside is, even when you have an Advantage plan, your prescription drug out-of-pocket expenses don't count towards that out-of-pocket maximum. So if your major expense is prescription drugs, and that's why you're leaning towards Advantage plans, you may want to think twice about that. Benefits, again, it's easier to navigate. There's only one plan you're dealing with. Downside, smaller network of providers. So if you want to go to another hospital out of state, you likely won't be able to do that. It's hard to compare the two, any two Medicare Advantage plans against each other because none of them are exactly the same. But typically you do get added benefits without extra costs. So really, there is no, again, one size fits all to any of this. And there are many people that lean one way or the other based on their circumstances. And so if you're really struggling with, I have no idea which lane I should be driving in, which is the best for me to access the care that I need for the least amount of money out of pocket, that's certainly something that we can help you walk through on our navigation program. We cannot tell you buy this plan or buy that plan, but we can walk you through the different pros and cons. Okay, I'm shocked that I'm not seeing the Q&A like get out of control, but I'm guessing there are going to be questions. So the last type of insurance coverage that I want to, actually not the last type, the last government type of insurance coverage I want to talk about are military coverage. So there are two main places that someone might receive coverage through the military. And the first is TRICARE. And this is for individuals who are currently active duty or who have served for over 20 or more years and now have something called TRICARE for life. TRICARE is its own beast, certainly. We do have a quick guide to military insurance. And from my experience, the representatives of TRICARE are actually incredibly helpful. Where we see people run into sort of challenges is if they have TRICARE for life and they also have another type of coverage, how the two work together. There's literally an entire booklet called Who Pays First for Medicare. But another type of coverage that many people have after they've served in the armed forces is Veterans Health Administration coverage. Now, VA health is often misunderstood. It's complicated. It is not always free, even if you have served. So many times there is a means test, which means based on how much your income is, you may have to pay a certain amount. It's on a sliding scale. VA health can be fantastic as secondary coverage. However, if you are also eligible for Medicare, do not decline Medicare because you have this VA health, because VA coverage does not count as creditable coverage for Medicare Part B. And so if you decline B and then you go to use certain services, VA might say, we're not covering that, you should have Part B. You go to try to get Part B, and now you're paying a penalty for life because you didn't pick it up when you originally should have. Many times people are not told this information. So the message, anyone who has veterans health on this line today, is if you're Medicare eligible, make sure you pick up at least Part A and Part B in addition to your VA health. Okay, finally, we're at the top of our triangle of coverage, which is individuals who go directly to an insurance company to purchase their health insurance. How do we actually do that? Well, certainly you could go straight to an insurance company and just purchase something. But the Affordable Care Act also gave us a new way to shop for insurance. And these are the state health insurance marketplaces. When the law was originally passed, they were called exchanges. Turns out no one knew what the heck an exchange is. So they renamed them health insurance marketplaces. People still don't understand them. The easiest way for me to explain them is think about a shopping mall for insurance or Amazon for insurance. The marketplace is just the platform that you are using to purchase the product. But the product is individual insurance policies sold by private insurance companies. So for the people who say to me, I have Obamacare, my response is often, you don't, because there's no such thing. It's not government insurance. It is sold by private insurance companies, Aetna, Humana, Blue Cross Blue Shield. So if it's sold by private insurance companies, why would someone go through the marketplace? Why not just go straight to the insurance company? There are a couple of reasons. The first is that policies sold in the marketplace have to meet a minimum level of coverage. So there's some quality control with respect to what you're buying. There's also a cap on the out-of-pocket maximums for plans sold in the marketplaces, and I've given you those dollar figures here. So again, this is a lot of money, and I'm not saying it isn't, but when we think about our Dan example and his $102,000 hospital bill, these out-of-pocket maximums allow us to plan for that worst-case scenario. The other major benefit, there is financial assistance to both purchase a plan in the marketplace, and those are called premium tax credits. And there's financial assistance for some people for things like deductibles and cost share. So it's based on your household size and your income level. And we do have a quick guide to marketplaces on our website that has a chart that shows you, based on your household size and your income level, how much you would get in financial assistance. And we're going to talk in this next section about how you actually figure out how to pick a plan. So with that information, about where we get our insurance under our belt, now the rubber is going to meet the road, and we need to figure out how we actually go about picking the plan. And because I recognize that health insurance can be a little bit dry, we have cartoons. When we are thinking about picking plans, the very first question I typically have to ask somebody is, what type of insurance are you eligible for? And then I have to think about where we are in the year. Excuse me. And that's because there are certain times of year that we are able to make changes or purchase our policies. Medicaid applications are accepted year-round. So as soon as somebody becomes Medicaid eligible, they can put in an application and their coverage will begin. Medicare actually has multiple enrollment periods based on several situations, but for everybody, there is an annual open enrollment period each year, and that is between October 15th and December 7th. And this is the opportunity for somebody in Medicare to decide, do I want to stay in lane 2, or do I want to drive back over into lane 1 with original Medicare? So you can switch between the 2 lanes both ways. You can also change your Part D plan. So let's say now you have a new drug that you've been prescribed and your existing Part D plan doesn't cover that, but there's another one that does. Open enrollment is your opportunity to make that change. You can pick up Medigap plans, you can change your Part C plans. So there's a lot of shifting that can occur during open enrollment. Most employer plans also have an annual open enrollment, typically in the fall. And then marketplace plans are in the fall. Now, there's a question mark here because we've now had the Affordable Care Act through, this is our 3rd presidential administration, and each administration has had a different time frame. So we aren't 100% sure that these dates are in stone yet. We are still waiting for the Biden administration to announce, but we suspect that open enrollment for the marketplaces will be between November 1st and January 15th. But Medicare plans and marketplace plans are calendar year plans, which means even if you pick a new policy on day 1 of open enrollment, that policy isn't going to start until January 1st. So it's very important to make sure you keep whatever coverage you have until your new policy kicks in. Now, the good news is the ACA and Medicare recognize that things don't just change during open enrollment. So both entities have a special enrollment period. And so this is when you are losing coverage or you're having a life-changing event, like you're leaving your job or your family has changed or you've gotten married. It triggers a special enrollment period. And in the marketplace, that means you have 60 days to purchase a totally new insurance policy. So that could be based on your situation in March, it could be in July. Medicare also has a special enrollment period, and you'll see that based on what we're talking about, it's slightly different. So if somebody, let's say, is retiring or they're losing their employer-sponsored coverage, they have 8 months to pick up parts A and B and D or C. You also have 6 months after your Part B plans to pick up a Medigap plan. So all of this is to say, if someone has coverage, like through a job, and then they become Medicare eligible, they may not need to start paying for Medicare right away, and they won't be imposed penalties as long as that coverage they have through their employer is considered comprehensive or creditable. So big picture, what that means is if somebody's in a situation where they're losing their employer-sponsored insurance, and that could be because they're retiring or they're getting a divorce, or maybe they just can't work anymore due to their medical condition and treatment, we actually have more options than we've ever had in the past. So option 1 is keeping the exact same health insurance that we had when we were employed through COBRA or state COBRA. Option 2 is picking up a totally new health insurance policy through the state health insurance marketplaces during a special enrollment period. And that could come with some financial assistance to do so. Lane 3 is maybe there's another group plan you're eligible for. So could you go on your spouse's plan at work? Or if you're under the age of 26, could you go on your parents' plan? And then lane 4 is maybe now based on circumstances, you're eligible for Medicaid or Medicare. So we get to actually choose which lane makes the most sense for us based on our circumstances. The trick with this, though, is you have to pick a lane and stay in it until the next open enrollment period. You don't get to change lanes once you've chosen. And here's where this comes into play. Someone will be leaving their job to deal with their medical condition and their treatment, and they're overwhelmed and things are crazy. And so they're handed COBRA paperwork and they sign up, and then they get 3 or 4 months in and they call me and they go, this is so expensive, I can't pay the monthly premiums. Can I go get a marketplace plan now and get some financial assistance? And the answer is no, not until the next open enrollment period. And the soonest it will start is January 1st. So you have to keep that COBRA coverage until January 1st. So we have multiple resources to help people navigate this because we recognize that it is complicated and one of the most stressful pieces around big life changes like leaving your job. We have an animated video that walks through the different options, and we have a quick guide. We also have a webinar that walks through these options as well. And then, of course, if after looking at all of those resources, you still have questions, you can feel free to set up a navigation appointment with us. Okay. We have all these options for health insurance. Fantastic. How do we actually make choices between those different options? I'm going to go through an example using 3 marketplace plans. but know that this analysis that I'm about to walk you through works, whether you are trying to compare marketplace plans, whether you're trying to compare between plans that your employer is offering, whether you're trying to decide, well, do I take my employer plan or do I say no thank you and go purchase a policy in the marketplace because we're not actually required to take our employer plan? Or if you're trying to decide between different Medicare Advantage plans, this exact analysis works. So here's how we do it. Here are 3 different policies being offered to an individual. There is a bronze plan with a monthly premium of $173, a $6,000 deductible, and a $6,000 out-of-pocket maximum. Then there is a silver plan with a $271 monthly premium, a $2,500 deductible, and a $5,200 out-of-pocket maximum. And then finally, there's a platinum plan with almost a $400 a month premium, a $0 deductible, and a $1,150 out-of-pocket maximum. So it begs the question, which is going to cost me the least by the end of the year, assuming that I'm going to hit the out-of-pocket maximum, which is a safe assumption when you're dealing with a serious medical condition. Can we tell just by looking at this information? I certainly cannot. I actually have to do the math. And the way that you do the math is you take the monthly premium and you multiply it by 12, because that gets you what you're going to pay in premiums for the year. And then you add the out-of-pocket maximum. And when you do that for all 3 plans, monthly premium times 12 plus out-of-pocket maximum, we then get the total that we're going to pay out of pocket per year. And when we do that, we can see that actually it's the platinum plan that's over $2,000 less expensive by the end of the year. So I will fully admit, depending on where you are in the country and which plans you're looking at, this could come out all sorts of different ways. But the point is, when you're trying to figure out how do I protect myself financially and which plan do I pick, which is the best plan for me to pick to do that, you can't figure out that information without looking at this math problem. But of course, this is only one piece of the puzzle. The other parts of it is looking at the deductible. So sometimes what happens is the platinum plans are actually the most expensive by the end of the year, like pretty close to some of the others. Sometimes it might actually be worth it to pick up that platinum plan because of the $0 deductible. Because what that means is that that policy picks up 90% of that person's healthcare costs right away, and then they only have to pay $1,150 out of pocket. And then the rest of their care is covered at 100%, except for those monthly premiums. So yes, the $400 a month is a lot to pay every month, but for most of us, it's easier to pay a little bit more each month than to pay less each month and get hit with a $6,000 deductible. Because that means I have to write a $6,000 check before the insurance company starts picking up anything. And that's typically harder for people to do than to spread it out for the full year. Now, of course, the other pieces are you need to make sure that the doctors and hospitals and other facilities that you want to use are in that plan's network. You remember way back when I started and I was talking about out-of-pocket maximums, and I said the devil's in the details because most of the time, insurance companies will only count payments made towards in-network services towards the out-of-pocket maximum. So if you pick a policy that doesn't cover the providers you want to see, and most of what you're paying out of pocket isn't getting applied to the out-of-pocket maximum, then that's not going to be a very useful policy to you. The same goes for prescription drug coverage. You might pick the most affordable policy based on doing that math, but if it doesn't cover the prescription drugs that you need to take it's not a useful policy. So I am a firm believer in the idea that hearing this information once or even twice often isn't enough to have it really sink in, and that what people then get, they understand it, great, fine. Then they get to open enrollment and it's sort of like, wait, what was I supposed to do again? If you feel like that, we do have the animated video on picking a plan that again walks through the example that I just gave you, that's about 5 minutes long and you can watch it at your leisure. But now I'm actually going to put you all to work, a little bit of a test to see if you're all still with me. I'd like you to meet Chandler. Chandler is being offered 3 different health insurance plans from his employer. An HMO with a $25 a month premium, a $2,500 deductible, and a 70/30 co-insurance, and an $8,000 out-of-pocket maximum. A PPO with a $100 a month premium, a $1,500 deductible, and a $6,000 out-of-pocket maximum. And a second PPO with a $200 a month premium, a $0 deductible, and a $4,000 out-of-pocket maximum. So assuming that Chandler is going to hit his out-of-pocket maximum due to his medical needs, which plan is going to cost him the least by the end of the year? So I'm going to give you just a minute to look at it, and then I'm going to ask Bob to launch the poll again. All right, Bob, can we go ahead and launch? Thank you. Well, very nice. It does in fact appear that you all are still with me. I love it. So for those of you who chose Plan C, you are in fact correct. So let's go through it together just to make sure we're all on the same page. So how do we figure this out? We take the monthly premium times 12 and we add the out-of-pocket maximum. The monthly premium times 12 and we add the out-of-pocket maximum. And yep, the monthly premium times 12 and we add the out-of-pocket maximum. So when we do that, we can see that Plan C with the $200 a month premium ends up being significantly cheaper than the other plans. But even if it wasn't, there are 2 other main reasons why he might want to consider picking Plan C. The first is that $0 deductible, as I talked about in the last example. So that policy starts picking up 90% of his healthcare right away. And it does, yes, he has to pay more in his premiums, but it's going to spread it out through the rest of the year. The other major reason is it is in fact a PPO. So it means by definition, he is going to have more choice in the providers that he can see. And he doesn't have to always start with a primary care physician. So there's more flexibility involved with a PPO. So this is really just to illustrate here that the same analysis works even if you have employer-sponsored plans. All right, so how do we actually figure out, well, what plans are available to me? It is going to depend on what type of insurance you're interested in purchasing. So if you are interested in purchasing your own insurance through the marketplace, healthcare.gov is the main website to do that. Now, some states run their own marketplaces and have their own websites. However, you can always start at healthcare.gov. One trick, however, is if you just want to window shop without putting in too many details like phone numbers or emails or anything, you just kind of want to see what's available to you. If you type in healthcare.gov/C-plans, it doesn't ask you any personally identifiable information. If you just go to healthcare.gov, you're going to have to set up an account to actually get in to see your plan options. So as I mentioned, some states have their own marketplaces, but you can always start at healthcare.gov because the very first question they're going to ask is, what state do you live in? And based on your answer, it's going to kick you to the right place. Now, I'm going to show you some of the tools that using the online system provides us. But I also recognize that some people either don't feel comfortable on the internet or don't have internet access. And so there is a toll-free hotline. You can mail in a paper application. You can even go and get in-person help. Now, this in-person help is called in-person assisters. And these have been a little bit challenging because they were funded through the Obama administration. Funding was cut significantly through the Trump administration. The Biden administration has just increased funding for next year. So we hope to see more assisters for this next open enrollment. It used to be that when you went to this website, localhealth.healthcare.gov, and you put in your zip code, you would only get assisters. And assisters are trained in the marketplaces, but they're funded through the government. So they have no vested interest in you picking a plan from one company over the other. That is very different than health insurance brokers or agents. Brokers or agents get paid based on selling you a particular policy. So they do actually have a vested interest in you picking one thing over the other. We also know that while there are some phenomenal insurance agents and brokers in the world, there are some not so phenomenal ones too. And the Government Accountability Office in the last administration did a survey or a study, and they found some pretty horrendous behavior on the basis of brokers. Things like saying that Obamacare wasn't in effect, or it would absolutely cover something that it wasn't going to cover, or that it was a marketplace plan when really it wasn't. And so for people who are particularly nervous about accessing help because they're not sure if they're going to get the right answers, it may be beneficial when they go to this website to find local help to actually X out agents and brokers so that all they're looking at are the assister organizations. I find that from a lot of people that I speak to helps calm some nerves because they are so nervous about picking the wrong type of policy. So all of that is just to say that if you need help, it exists. So for the people who are asking about specific policies, those in-person assisters could be really helpful. The other thing that the online system provides us is a way to check if providers and prescription drugs are covered by a particular policy. Now, here's just a word of warning about that. It is a little bit of garbage in, garbage out, because these lists aren't kept as up to date as potentially they could be. And so I don't suggest that anybody rely 100% on what they find online. But before they pull the trigger and purchase the policy, they also call their providers and double check, hey, you do in fact take this plan. Now, don't say, do you take Obamacare? Because I promise you they're going to say no. You probably don't even want to say, do you take a marketplace plan? Because typically they'll say, no, we don't. Use the exact name of the policy. Do you take Humana Gold 305? Oh yeah, we take that. So it does take some extra legwork on your part, but it can save a lot of headache later on. Now, the great thing is Medicare has almost the exact same tool for Medicare plans. It's called the Medicare Plan Finder. It's available on Medicare.gov. And it's slightly different based on if you're trying to drive in lane 1 or lane 2. So if, for example, you're trying to drive in lane 1, which is original Medicare with a Part D plan, and you want a Medigap policy, this is the first screen. You put in your zip code. Then you say, well, am I getting any sort of financial assistance? If you don't know, just click I don't know. It asks you if you want to learn about your prescription drug costs. I highly recommend that you do so. It then will ask you, how do you fulfill your prescription? So do you go to the corner CVS or do you do mail order or both? Then it asks you to actually put in the drugs that you are taking, the dosage, the frequency, and you can add multiple drugs here. So add in all the drugs till you've added in everything that you're taking. You can give some information about the pharmacies you go to make sure that those are in network. And then out pops your options. And so this person has 28 different drug plans available to them. You can see there's some information about the monthly premium. So they're going to pay $13.20 for that policy, the deductible, and then an estimated out-of-pocket cost. And so you can go through these different plans and see which one makes the most sense for you. It only shows you Part D here because you've chosen original Medicare. And so A and B are the same for everybody. If instead on that first page, you said, I want an Advantage plan, I want to drive in lane 2, you answer almost all the same questions, but your end screen looks a little different because now we're looking at, well, what does it cost you to have your A and B bundled? And you see here where it says $0, that's what I was talking about earlier, where it's not actually free because in teeny tiny letters, it says it doesn't include your standard Part B premium. But this also will show you, is there a deductible and what's the out-of-pocket maximum? It may also show you your estimated yearly drug costs as well, based on what you've included. If you're looking for a Medigap policy, there's no real easy way to do it, to be 100% honest. On Medicare.gov, there is a place where you can put in your zip code and it will show you the companies that sell policies to people in that zip code. But then you actually have to go and call each one of the companies to figure out what plans they offer and how much they are going to charge. So there is definitely some legwork involved in the Medigap piece of it. And you probably do want to be a savvy consumer and shop around before deciding on one particular policy. So with that, I think we are going to take a quick break. And I'm going to turn it over to Muriel or Paula if they want to say anything before we break.
Oh, wow, that is so much. Thank you, Monica. And there's more, folks. We've got a lot more coming. And we're going to get to your questions. But right now, we will take that 10-minute break. Okay, we're ready to start. And we do appreciate you writing in your questions, and we will get to them. And now back to you, Monica.
Thank you. All righty. So the good news is hopefully you all are feeling better about how many different options you could potentially have. The bad news is picking the health insurance policy is only half the battle. Once we have the policy, then we actually have to figure out how do we use the policy effectively. And sometimes the chips are stacked against us. So one of the things that people come across quite frequently is the concept of prior authorization. This is where insurance companies require that you go to the insurance company before you receive services or take a drug, and you basically ask them, can I have approval that you're going to cover this particular service? Sounds simple, but there are lots of challenges. One of the challenges is there are multiple names for the same concept. So you might be told you need to get a prior auth or get a pre-auth or a pre-authorization or a prior authorization. The other issue is that it's not like when you sign up for insurance, you get your insurance card and then you get this comprehensive list and it says, if you get anything on this particular list, you need a prior authorization. Otherwise, you're good. So it's sort of the wild, wild west for patients of like, well, do I need a prior authorization or not? The other challenge is many people falsely assume that it's the healthcare provider, the doctor or the hospital's responsibility to get the prior authorization. Now, many providers will do that as a service to their patients, and they will contact the insurance company and deal with all of that paperwork on behalf of the patient. But ultimately, at the end of the day, it is the patient's responsibility. So it is us as consumers of healthcare, it's our responsibility to get the prior authorization. What happens if you don't get one? Well, the insurance company could say, we're not going to cover that particular service, even if they would have covered it if you had gotten the prior authorization. So all of this is to say, you know, it's really challenging for consumers when they aren't given a list, they don't really know it's their responsibility, and then turns out that they got a service without one and now it's not being covered. So I don't really have a good answer or a good solution for you about prior authorizations, but I didn't want that to stop me from bringing it up because we see it be an issue frequently. So I personally tend to err on the side of over asking the insurance company. So anytime I think there's a service, you know, that's going to cost a couple $1,000s, I call and see if I need a prior authorization. I call the number on the back of my insurance card and I figure it out, because it's things like CT scans or MRIs or X-rays, certainly bigger things like surgeries or hospital admissions. Some very expensive prescription drugs could require prior authorization. So again, I know I'm putting the onus on you when you're already dealing with so much, but the challenge is if you don't get the prior authorization, you could be in a situation where you're not going to get a service covered. Certainly that could be something you appeal, which we're going to talk about in half a second, but it's not a guarantee. Now, prior authorizations aren't the only types of denials that individuals get. In fact, studies have shown that the rate of health insurance companies denying claims is skyrocketing. So 14% of all the medical claims end up getting denied. So what does that actually mean? We're talking about 200 million claims get denied each day. And when we talk about the financial impact of a serious medical diagnosis, this is the place where we think consumers need to be being more proactive. So what happens if you get a denial? Well, the good news is we don't necessarily have to take no for an answer. And we have a process to appeal those claim denials. Now, the process is going to vary based on which type of insurance you have. So step one, when we're talking about appeals, is you have to figure out what type of insurance you have and then follow the appeals process very specifically for that type of insurance. I recognize that sitting here today, that sounds very obvious, but we see on a pretty regular basis people who are pretty far down the appeals process only to find out that they didn't follow the right process for their insurance. When we're talking about appeals, generally speaking, there are going to be at least 2 levels of appeal. With certain types of coverage, like Medicare, for example, there are up to 5 levels of appeal. But for most insurance policies, you're going to at least have an internal appeals process where you go back to the insurance company and you say, please reconsider saying no for X reason. So maybe you're going back and you're asking for a retroactive prior authorization, or maybe you're going back and saying, no, this particular drug isn't experimental, it is medically necessary. And here's all the medical evidence and support from my healthcare team to show that. Sometimes it's about clerical errors, but more often than not, particularly in a disease state where there are novel drugs coming out, and where there's a lot of what's considered off-label drug use. So for example, the FDA has approved a particular drug for one type of medical condition, but then scientists figure out, oh wait, it's really helpful for this type of medical condition too. Insurance companies might say, well, we're not covering it for that because the FDA hasn't approved it for that yet. And that is something that could potentially be appealed. If you go back to the insurance company and do the internal appeals process and they still come back and say, nope, we're not covering it, you generally have at least one level of external appeal. And this varies slightly based again on the type of insurance you have, but if you have private insurance or marketplace plans or employer-sponsored insurance, this is available in all 50 states. And it's where you go to an independent entity and you basically say, you look at the policy and all the medical evidence that shows that this particular service, treatment, drug is medically necessary, because that's the legal standard you're going to use. And that independent entity looks at all the evidence and makes a decision. And that decision is binding. Now, this is again one of those things where it's an added thing to your plate when you've already got too much on it. However, we know that somewhere between 40 and 60% of all the appeals get decided in favor of the patient. So if we're being conservative with these numbers, it means that about half the time when an insurance company is saying we're not covering that, they're getting it wrong. And when we're talking about financial burden, this is an area where consumers really can take more control. But we know that the process is being wildly underutilized. So just looking at the marketplaces, of the 40 million claims that got denied in 2019, only 0.2% were appealed. Less than 0.5% of the claims that got denied were appealed. And I just told you that on average, about 50% of the time, when the insurance company says no, they're wrong. So this is money being left on the table. So to that end, to the importance that I place on the appeals process, at Triage Cancer, we have multiple resources to try to help you through the appeals process, including some quick guides and an animated video. We have a tracking form to help you keep track of where you are in the appeals process. But perhaps most importantly, for you all, based on the number of different types of insurance coverage that are represented today, on cancerfinances.org, we have a recently released module on appeals. And if you answer the questions in order, it will take you to the process specifically for your type of insurance. So I highly recommend that you check that out if you end up getting a claim denial. Now, I want to spend a few minutes, perhaps more than a few, talking about prescription drugs that many of you are taking and that many of you had questions about, particularly related to Medicare coverage. And I'm not going to lie to you, when the questions started coming in, it took me a long time to kind of sort through all of the answers because this is complicated. Partially because there isn't a super clear answer as to which part of Medicare covers a prescription drug. So based on the drug that you're taking, you would have to first ask, well, how is the drug given to me? How is it administered? And based on the answer to that question, you're going to have a general answer. So is it inpatient? Are you in a skilled nursing facility? If so, then Part A is actually going to cover it. And the cost share associated with Part A is what you're going to end up paying. Is it something that is, you go to a doctor's office and it's either an infusion or an injection that a healthcare provider has gotten and actually gives you? If so, then it's probably covered under Part B, which means that you have that 20% coinsurance. Or is it something that you maybe pick up at a pharmacy or a specialty pharmacy and you administer it? So either you give yourself the injection or it's a pill that you take. Typically in that situation, it's going to be covered under Part D. So when you all started throwing in, you know, how do I deal with the drug costs? I really had to start looking at, well, how is this drug administered to be able to figure out which part it falls under. But there are all sorts of exceptions to the general rule that I just gave you, because original Medicare was passed so long ago that we now have science that is way beyond how the original framework was provided. And an example of that is oral chemo. So technically, oral chemo is a pill that you take. So based on my last chart, that should be covered under Part D. And it is, except when it was once only available as an IV. And so then it's actually covered under Part B. So I recognize that you all aren't going to completely have this all sorted out, but I really just wanted to illustrate that oftentimes it isn't a quick answer. And in order to try to effectively answer your questions today, I actually enlisted the help of Muriel and Paula to create this chart. And I know it's a little bit tough to read on the screen, but Paula has dropped a link to a PDF of this chart that you can take a look at. But this is just sort of a breakdown of the drugs that most people were asking me about and the companies that create the drugs, how it's administered, and then based on that, what part of Medicare covers it. So for example, here we have DARA, which is an injection that's provided by a healthcare professional. So that is going to be covered under Medicare Part B. Now, Medicare Part B does come with the 20% coinsurance. So how do we protect against potentially high costs there? Well, that's where a Medigap plan could be very helpful. Let's look instead at tafamidis, which is taken orally. That drug is covered under Part D. Part D has that donut hole we talked about, the 25% coverage until you get to a certain amount, and then you pay 5% with no out-of-pocket maximum. Will a supplement be helpful for that particular drug? No, because Medigap plans don't pay for out-of-pocket Part D plans. So then some of you might be thinking, well, great, I'm going to get an Advantage plan that includes prescription drugs, and that's how I'm going to deal with it. But the problem is with Advantage plans, if you remember, the out-of-pocket maximum doesn't include payments made towards prescription drugs. So the bad news here is, as of right now, there isn't a great way to protect yourself in Medicare coverage from high out-of-pocket costs that are covered under Part D. It's the reality of the situation. We're going to talk about some advocacy opportunities in a few minutes. Now, there are also some places where things get a little bit tricky, and it is beneficial to have a conversation about your concerns around costs with your healthcare provider. And here's an example of that. So here is a drug that can be an infusion where you go and you sit in, a room and it's infused. It can be an injection, and that injection could be administered by a healthcare professional, or it could be a self-administered shot. And based on how you actually get the drug is going to determine which part of Medicare it's covered under. So I bring this up because if somebody says to me, I don't have a Part D plan and they're trying to take this drug, what I would say back to them is talk to your provider to see if they can give you the injection and then bill it under Part B, or get the infusion instead of the injection. Now, I realize there are some practical downsides. You know, you don't want to sit in an infusion chair. I recognize all of that. We're really just talking about the cost piece right now. And I'm only using this as an example that occasionally there are different decisions that can be made that are equally effective medically that can have a significant financial impact. And so really, it's just to encourage you to have the conversation with your healthcare team. And as you can see, that was just one example of the many that I found where there would be a choice. But not all of them obviously do. So if someone has a drug that they are taking that is covered under Part D and has high out-of-pocket costs, there are a couple of things to be done. So the first is if they have a high out-of-pocket cost because the drug was denied, because maybe it was considered experimental, absolutely start with the appeals process. That should be step number one. If instead it's just that, you know, they're into catastrophic coverage and they're paying 5%, and 5% of expensive drugs is a lot of money, then they're going to likely have to look at charitable foundations. Sometimes there are state assistance programs, but also this is the opportunity to look to the year ahead to see if they can pick differently for the next open enrollment. And this is particularly useful if, for example, you've picked a Part D plan that doesn't include a particular drug in their formulary, but that there are other Part D plans that do. Open enrollment is your time to switch out of that Part D and get into one that does cover it moving forward. There are also some individuals who are eligible for both Medicare and Medicaid. And these individuals are kind of labeled something differently depending on where you are in the country. So maybe it's dual eligibles or duals or Medi-Medi. And typically what happens is Medicare is the primary payer. They pay first. And then Medicaid sort of acts as a Medigap plan. But they can also be very helpful with some prescription drug costs and for other services that Medicare doesn't cover. So if you aren't sure, based on what I've shared with you today about Medicaid, and if you're eligible and you're on Medicare, it might be worth it to go and ask to see if you might be dual eligible. If you aren't eligible for Medicaid, but you do have a lower income, there are some other programs through Medicare to help you pay for some of the out-of-pocket costs through Part A and Part B. Collectively, these are referred to as Medicare savings programs. As you can see, there's multiple different programs and they have different eligibility and different things that they pay. And this is one of the things that we have a quick guide on specifically on Medicare savings programs. But if you're trying to get help paying for your Medicare Part D costs and you have a low income, there are two programs. Primarily, it's through something called Extra Help, also known as the Low Income Subsidy or LIS. Why we need three names, I don't know, but here we are. And Extra Help is based on income and can be very, very useful if you are taking a high cost Part D covered drug. Some states also have something called a state pharmaceutical assistance program that can help pay for some or all of your drug costs. Now, I know we've spent a lot of time on Medicare. I can see the questions ticking up. I'm sure there are still questions which I'm happy to go over, but please know that there are other places to get this information. If there are healthcare professionals on the line today, please feel free to share this with your patients. And you can always join us next month for an hour-long webinar just on Medicare. Now, we've picked a plan. We've gotten savvy about navigating our plan using in-network providers and prior authorizations, and we're appealing denials. We're not done because we actually have to do this whole process of picking a plan every single year. And that's because things change. So your needs change, your life changes. Maybe you've moved or you've gotten married. Maybe you're now taking a prescription drug that you weren't taking prior. Maybe your last plan actually changed its formulary, so it's no longer covering a particular drug that you're taking. Open enrollment is our opportunity to review what we are going to have for the year coming forward. And for every single person that I talk to who is dealing with high out-of-pocket costs in health insurance, it often comes down to, did they really look at what their needs were for the year coming? Now, I realize sometimes it happens mid-year, but to the extent we can predict, it's to our benefit. And then also, certainly, if we are ever changing jobs, that's another opportunity to look at that as well. And we have 2 checklists that could be helpful for you in that regard. But even if we've picked the most perfect plan and we've done our due diligence and we did the math and we looked at the formulary and the network, there's still going to be bills. When you actually get the bills, be prepared for multiple pieces of communication. So just from an insurance company, you could get something saying, we've gotten a claim, now we're processing it. And then you're going to get your explanation of benefits. And your explanation of benefits, or your EOB, is one of the most important things for you to be looking at as you're receiving care. The telltale sign, this is not a bill. Somewhere it's also going to have some information about the policyholder and how much was billed. It's also going to have some information about the actual services you've received. Now, a good EOB may actually have words. Not all of them do. Many of them just have a code. Thankfully, thanks to the internet, they're all Googleable now. But you really want to look and make sure that you actually received all of the services that you're being billed for. We see crazy mistakes happening all the time. So being charged for 11 MRIs instead of 1 because they accidentally hit 1 twice, or being charged for something that maybe was ordered but you never got. So just checking to make sure it's all accurate and that the math all adds up. And then ultimately you're going to see what you're responsible for in the corner here. A good EOB will also have some information about how much you've paid towards your deductible and how much you've paid towards your out-of-pocket maximum. And the reason it's really valuable to look at this as you go is because many times things don't always sync up, particularly if you're getting a lot of care all at once. So you might have an EOB that says you've met your out-of-pocket maximum, but then you go to your doctor and they're like, we'd like your $35 copayment. If you understand your out-of-pocket maximum and you know you've already met it, you can tell them at the front desk, I've already met my out-of-pocket maximum. They might push back a little bit, but you need to be empowered to know that that's what's happening. And then finally, the last communication you're going to get is from the provider. And this is going to be the bill with just generally how much you owe. The practical piece here is that it often doesn't happen in this order. Providers are typically much faster at sending you the bill than the insurance companies are at processing the claims. So if you get the bill and you just pay it before you've gotten the EOB, you might be in a situation where you've overpaid and now you're going to have to try to get money back from the provider. So the general rule of thumb is to wait until you get the EOB to pay the provider. Now, this shouldn't happen in a vacuum. Make sure that you communicate with the provider. Call them up and say, I've gotten the bill. I haven't gotten an EOB yet. Can you make a note in my file? Or can you push back the due date for the bill? Because if you just don't say anything and months go by, the provider could potentially even send you to collections, worst case scenario. So when you're reviewing bills for accuracy, in my example, it seems super easy, but when you're getting multiple EOBs, every other day, and you've got piles of mail and you're not feeling well, this is a lot. And so there are some professional entities that can help you navigate all of this. One of those entities is called Co-Patient. They are a for-profit company. We have partnered with them, and as part of our partnership, Co-Patient is offering their services to anyone that signs up through Triage Cancer's link for a year for free. You have to sign up by September 30th through this link in order to get access to the program. You can cancel it at any time. There's no commitment to move forward. But really, we're trying to show that people are struggling to do this on their own, and we want to provide a service. And Co-Patient is really trying to show the value of their services. So there really is no catch. And I highly recommend that you check it out if you are struggling with lots of bills coming in and you're not sure where you are and what you owe and what you've paid. They're an incredibly useful service. So this is just our checklist of how we can go about making the most of our health insurance for all of us. So making sure we're using in-network providers whenever possible, we're asking for prior authorization, we're paying attention to bills and checking them against our EOBs. We understand our out-of-pocket maximums, and then we leverage that information. So if you've hit your out-of-pocket maximum for the year, thinking about, is there other medical care that you might need that maybe you've been putting off? Completely unrelated to your amyloidosis. Is there anything else that maybe you should need to go get taken care of? Maybe you do that this year where it's going to cost you nothing rather than waiting until next year where everything starts over at zero. It could also be about timing. So for example, a woman called us and said that she was surprised she had to pay for some of her chemotherapy treatments. We worked it out with her, and basically what happened was she decided she wanted to hold off on treatment until right after Thanksgiving. So 2 weeks after, enjoy her Thanksgiving, then she was going to start treatment. Because she waited, it pushed 2 of her treatments into January. Well, in January, everything starts over at zero. And so she then had to pay her full deductible and the full co-insurance for those 2 treatments. So sometimes it's about just paying attention and leveraging that you know you've met your out-of-pocket. And sometimes it's about timing. And then of course, I know I sort of beat this to death, but appeal, appeal, appeal. When people say to me, I can't get a drug covered or this was denied, the answer is appeal. There's no other way to deal with those denials. Now, it certainly could be helpful for you as an individual because you could get that service covered, but it's also potentially helpful for the entire ecosystem, because we know that if departments of insurance are getting appeals over and over and over about a particular topic, or about a particular service, or like the inspector general at the VA is getting tons of appeals on one particular drug, they might actually take a step back and look at their coverage determinations and make changes. But if nobody's appealing, in their mind, there's nothing wrong and there's no changes that are needed. So the appeals process is incredibly, incredibly valuable. The last couple of minutes before I get to questions, I want to switch gears and talk about what you all can do. Because while there are lots of answers to the questions that I got, there were some that weren't good answers. And the reason for that is because of the way that the law is currently written. So there's a lot of great things that the law has provided us as consumers, but there are certainly still some gaps. And so when we talk about advocacy, we really do believe it means that there's all sorts of advocacy. And so everybody should be engaging in personal advocacy. And that's really where the idea of appeals falls into play, and talking with your providers. Certainly, I think that there are opportunities for policy advocacy. So even when you don't necessarily need a law to be changed, there are places where we can still see improvements. And the VA is another great example of that. But then there's definitely opportunities for legislative advocacy within the amyloidosis community. Some of those things are specific to your community, some of which are kind of bigger, broader healthcare community in general. And so we really want to empower you all to be advocates wherever it makes the most sense for you, and to know that at Triage Cancer, we have tools and trainings to help you become an advocate if that's what you're interested in doing. You do not have to be a lawyer. You don't have to be well-versed in the laws. You just really have to have a passion for change. And some of the specific advocacy opportunities that came up in the questions, but then also have come up in other events that I've been at for your community, back when we did in-person events, have been things like with Social Security disability insurance, which is one of the long-term disability insurance programs through the Social Security Administration. If somebody is dealing with a disability so severe that they cannot work, and therefore they're eligible for SSDI, there is a 5-month waiting period before cash benefits begin. So that's 5 months where somebody is dealing with a severe medical illness, they can't work, but they also aren't collecting any disability insurance. And so we see it being a really practical problem for people in all sorts of healthcare communities. And so certainly that's an opportunity for advocacy to eliminate that 5-month waiting period. Another opportunity is once somebody gets on SSDI, they have to be receiving benefits for 24 months before they become eligible for Medicare. And when you think about that practically, we're talking about an individual whose disability is so severe they cannot work. And yes, they're collecting SSDI payments, but those typically aren't a huge amount of money when we're talking about covering all of the medical bills, plus helping someone figure out where to get health insurance because they need the health insurance coverage to deal with their medical illness. So here someone has to wait 24 months before they become Medicare eligible. And so again, huge practical problem for individuals with disabilities. So another advocacy opportunity would be to eliminate or reduce the amount of time someone has to collect SSDI before they become Medicare eligible. A big one that I think would be very helpful for this community in particular would be creating some sort of out-of-pocket maximum for Medicare Part D coverage, or having some other type of supplemental plan that somebody could purchase to help deal with the out-of-pocket costs associated with Part D. Because we know that as these novel, amazing therapies continue to get produced, the prices are going to continue to go up, and there has to be some changes to how Medicare helps support people who need those particular drugs. And then we've seen some other changes within Medicare that were sort of a result of the pandemic. So for example, covering telehealth, so virtual healthcare visits, and allowing certain medications to be infused at home rather than someone having to travel to an infusion center. Medicare coverage for those things was sort of emergency granted due to the pandemic, but there were a lot of benefits to those things for the community. And so there are some efforts to make those permanent within Medicare. And so those are just some examples of where there could be improvements to how existing law operates. But if legislative advocacy just isn't your thing, I have good news for you. Muriel and Paula talked about an opportunity to engage in scientific advocacy earlier today, and that's the survey that they mentioned. And it's the evaluation that they asked you to complete at the end of today. By providing your feedback and allowing people to improve programs and gather data, that's engaging in scientific advocacy. And so pretty easy way to engage and benefit your community. So I often get questions, when I say I'm a cancer rights attorney or I'm a healthcare rights attorney about what's legal about cancer? And really the answer is almost everything. Most of healthcare comes down to something in the law. And so while we've talked extensively about health insurance today, I know we didn't spend a lot of time talking about disability insurance or employment rights or estate planning, But again, those are all things that you can get more information about on our website. So I'm going to punt it back over to Muriel, and I'm happy to answer questions.
Thank you so much, Monica. Before we get to questions, we do have one more thing, but you brought up so many interesting points. The one I liked was the appeal process is actually a way of doing advocacy. And so, even if you don't want to appeal, if you can appeal, because the squeaky wheel gets the grease, and you'll be helping a whole bunch of other squeaky wheels get some grease. So I think that's a great idea. And we do have some questions to get to, but I know Paula has some financial assistance information that she wants to share. So that'll just be a couple of minutes. So Paula, are you there with some financial assistance? Oh, and by the way, Paula, we do so much appreciate your putting all those helpful links in the chat. It's really great. Thank you.
You're welcome, and hello, everyone. I'm going to wait for Bob to pull up the slides here. I just have a few slides today to help explain to you some of the financial assistance that is out there and what it's based on. Now, this is financial assistance from foundations, from drug companies, from 501c3s, from groups like the Leukemia and Lymphoma Society, that type thing. But most of them will all have a set amount that you have to fall within as far as your income for the year. The majority of these, you can make up to 400 or 500% of the Federal Register for Poverty guidelines. You could be 400 to 500% above the poverty guidelines. This chart that's on the screen now shows you the amount of money you can make each year and qualify for those programs. If you're in Alaska and Hawaii, you see it's a much higher amount. But just pay attention to those amounts on the screen there to kind of get an idea if you fall within it or not. Now, you'll have to check with each individual program to see which threshold they use for their determination, but you can find that on the website. And on the next slide, I have some of those websites. Okay, the Leukemia and Lymphoma Society will cover AL patients with myeloma. You can get up to $11,000 per year in financial assistance. And one of the good things about that program, you heard Monica mention earlier today about COBRA insurance, the Leukemia and Lymphoma Society program. If you qualify for that, you can pay your COBRA premiums with that program. They will pay them for you. This covers other people with different types of blood cancers. In addition to myeloma, we have Waldenstrom's, there's B-cell lymphomas, that type thing that can fall under those programs. But right now, this program is the only one that is open. Patient Advocate Foundation also has money available. I believe they did. But that money is available to AL amyloid patients. Check with Patient Advocate Foundation, which is copays.org, multiple myeloma program. They pay up to $12,000 a year. Now, don't think you can double up on these programs. You can't get money from both of them, but you could try one. If you don't qualify, you could try the other one. They may have different thresholds. If you are on daratumumab, also known as Darzalex, Janssen has programs where you can possibly get assistance in paying for your drugs. If you're uninsured, they have a program specifically for uninsured patients where you may be able to qualify for the drug for free. Next page, please. The ATTR financial assistance. This is from the pharmaceutical companies here. You can go to any of these websites, depending on the drug you're on, and they will walk you through their registration, and then you can get on the phone with some of the company officials and find out if you qualify for their programs. If you're not on Medicare yet, they have copay assistance cards that you may qualify for. But if you're on Medicare, then you fall into a different category and have to go with the foundation assistance. But be sure to contact one of these companies if you are on these drugs, because these folks can help you. Next slide, please. The foundations that offer assistance, this is a list of some of them. These are basically the ones that we know pay for these drugs that cover them. Healthwell Foundation, PAN Foundation, patientadvocate.org. Each one of these cover different things. Some cover both AL amyloidosis and TTR amyloid. So check with each one of those. The Assistance Fund, they also have it. Chronic Disease Fund. MyGoodDays.org will sometimes pay for those drugs like your lisinopril, your diuretics, any other type of prescription drug that you take. You can check for that. Always check with your pharmaceutical company too on pretty much any prescription you take. If it's an older one or a generic, you're not going to get any help on it. But if it's a new drug, a new blood thinner, let's say, they may have a copay assistance program if you are not yet on Medicare that you might qualify for and maybe get the drug for $5 to $25 a month, something like that. But always check with the pharmaceutical companies to see if there's a copay card if you're not on Medicare yet. Because a lot of people wind up missing out on a lot of assistance because they don't realize that is out there. Next slide, please. The Fund Finder, this is through the PAN Foundation website. They call this an app, but it's not really an app like we download for our phones. But if you go to this site, you can enter in the disease that you are interested in, knowing where there is additional coverage from foundations. I had typed in amyloidosis, and this is what comes up. See, it shows PAN Foundation, Healthwell Foundation, Leukemia and Lymphoma Society Assistance Fund. They have different programs throughout the year. These padlocks over here, unfortunately, are showing us that these programs are closed right now. Leukemia and Lymphoma Society still has money. So if you have AL, you can qualify for that money possibly. But go ahead and get signed up with this program, because when a fund reopens, they will send you a notification that, hey, Healthwell has just opened their funds back up, which most likely is not going to happen until December or January, somewhere along in there, because most of these companies are out of money for the year. So when you see that the funds are available, you need to jump on them then. Don't wait around and say, oh yeah, I'll sign up next week. No, by next week, all the money could be gone. You need to do it today. And when you see it open, try to get it done then. Because I've seen these programs stay open less than a week sometimes when they have funds available. So, just know there is help out there. I realize I've got a lot of addresses here. I'm going to post the links over here in chat so you can look there. But if you need them, you can email me at paula@amyloidosissupport.org and I will email them to you, no problem. Because there is assistance out there, and these are also available on our website. So just know there is help.
Thank you.
Some parts of the year there's help. Other parts of the year there may not be, but it will reopen, and everybody has to reapply each year. So you will have a chance to apply.
Thank you, Paula. I know everyone is very appreciative of that. And so let's get to some questions that we have. Okay, and remember, if you don't feel your question is answered or it's not answered adequately, you've got that link to on Triage Cancer that Paula posted, so that you can send in a request to someone, or maybe even you'll get Monica, who knows, right? Okay. Okay, Nathan, how and when can someone apply for federal disability benefits for multiple myeloma? Is AL amyloidosis on the federal disability list? Monica, maybe you'd understand that question.
Yeah, so I think you're asking about applying for Social Security Disability Insurance, or SSDI. And there's no specific list of if you have, these things you can apply or not. What the Social Security Administration will do is they will basically look to see if you have a disability that is keeping you from doing your job, that is keeping you from doing any other type of job, and is so severe that it's expected to last for a year or longer or result in death. That's the Social Security Administration sort of definition. If you meet that definition, then you can apply for SSDI. Now, there are some lists, like the Compassionate Allowances list, that will speed up the application process, but it will never get rid of the 5-month waiting period. So if you aren't sure if you meet that level or not, it's probably in your best interest to go ahead and apply. We also have an entire topics page on triagecancer.org on disability insurance. So if you have more questions specifically about the process, feel free to reach out.
Thank you. And I know for that speed up process, the compassionate list where they try and speed it up, they don't list amyloidosis as amyloidosis. It's very hard to find. They call it primary cardiac amyloidosis. So if you're looking in an alphabetical list, look for primary cardiac. And it's not, unfortunately, for ATTR cardiac. It is for primary, which is the AL form. It doesn't mean you won't necessarily get it if you have other types. It's just that it'll be sped more quickly. It's on a case-by-case basis otherwise, I guess. You're more umbrellaed in, I guess, if you have the primary cardiac. Okay, will this slide deck be available? I can answer that. Yes, we're gonna have this entire program available up on our website and our YouTube site. But Monica, maybe they won't be able to listen to your explanations. Perhaps you can send us the slides and we can make them available to people that ask for them. Would that be okay?
So I don't typically give out the slide deck, and here's the one reason why. It's because the information changes. And I don't want someone relying on old information. So if anybody is looking for this information, I promise you it is all available on our website, downloadable, and you'll know by going to our website, you're getting the most up-to-date information.
Wonderful. Okay. What is the best option for someone on Onpattro? Now, this would be an ATTR, likely hereditary patient, and prescription drugs required for life post-heart transplant. Okay, best option for someone. I would imagine they want to know what type of insurance would be the best option for someone who, I'm glad the question's for you.
Well, it depends is the answer, and it always is going to be the answer. If you're talking about under Medicare, that particular drug, to my knowledge, I'm sure someone will correct me if I'm wrong, but to my knowledge, that's covered under Part B. So if you were to pick up original Medicare plus a Medigap G, then that would be the way to protect yourself from out-of-pocket costs associated with that particular drug.
Okay. If go to that website and you can have a half hour with Monica or one of her colleagues if you're unhappy with that answer. Okay. If I choose a Part D plan because the formulary includes an expensive drug and the formulary changes to either exclude or reduce coverage for that drug, can I change to another Part D insurer? That's an interesting question.
So the short answer is yes. The long answer is it's going to only be available for you to change during the next open enrollment period. And so that's when I talk about, reviewing your options every single year to make sure the plan's still meeting your needs during open enrollment. So that would be your opportunity to change to a new plan. Now, the good news is if the Part D plan changes its formulary mid-year, and it changes it because it's a drug you're already on, they have to continue providing coverage to you for that drug as long as you can show that it's medically necessary. And so you'd at least have coverage for the rest of the year, and then come open enrollment, you pick up a new plan that has coverage for the year ahead.
Okay. If the drug used for the infusion is a very expensive $19,000 per infusion every 3 weeks for Onpattro, it sounds like Medigap G won't help with the drug costs. So is Medicare Advantage the only option? How do we know if they cover that drug? Didn't you say it was Medicare B that covered that?
Oh, Muriel, you get a cookie. Yes, so that particular drug is covered under Part B. So the Medigap Plan G would be the way to protect yourself.
Okay. Wow. Thank you. I'm glad I didn't make a fool out of myself. My husband's applauding me. Okay. I have coverage from my former employer. Can I add a Medigap plan? I'm confused on that one.
So I would want to know more information because I would want to know if you were also on Medicare and why you felt like you needed a Medigap. So that's someone that I'm going to suggest reach out to us and we can chat more about your details.
Good. Is tafamidis considered a prescription drug under Medicare Part D? If so, is there a maximum out of pocket? Ooh, yeah. Okay, go for it.
So I had to look down at my handy dandy chart. Tafamidis is covered under Part D, which means as of right now, there is no out-of-pocket maximum.
Okay, and that wonderful chart that you gave us and that Paula is making available on the in the chat is really helpful because it tells you all the parts that it's covered under. This is wonderful. Thank you.
You're welcome. I hope it is all accurate.
If it's not, you will hear it. Don't worry.
I'm sure.
Our patients are really smart. You know that. We were told that a pre-authorization for a tilt table test was not needed. Now they denied payment for that test. Is the appeals process the only way?
Yes.
Okay.
Look at that. I can answer a question short. Yeah, because here's the problem is that, again, the prior authorization system is very challenging. But if you've gotten a denial and you disagree with that denial, the course of action is to appeal.
Very good. Does this external IMR appeal apply to cancer policies also?
So just
can you repeat what that is? Because not all of us remember what an IMR is.
No problem. I know it was a lot. So IMR is the independent medical review or the external review. And that's where you basically have exhausted your time with your appeals within the insurance company. And now you're going to an independent entity asking them to reconsider. And that rule, the ability to have an external medical review, is only for health insurance. If I'm understanding what she's asking about, this is a cancer policy, which is another type of insurance policy, a supplemental policy that you can purchase. AFLAC is a really common example of this, where you purchase a policy and basically if you get your cancer screenings or if you get diagnosed, they send you money. The same appeal rights don't exist outside of the health insurance arena. And so the blanket answer is no. The longer answer is if you have an insurance product that you feel has acted inappropriately and denied you inappropriately, you could reach out to your state's Department of Insurance and ask them to look into the situation. And if you're interested, we have the contact information for every state's Department of Insurance on our resources by location.
You know, a question just occurred to me from our patient that asked about the Onpattro, which is covered under Part B. But if someone were getting home infusions of Onpattro, that wouldn't be administered by the doctor. That would be, would that be considered Part D or Part B?
Good question. Are we in pandemic or out of pandemic? Because
well,
Medicare doesn't typically cover home infusions. And so that's where I was talking about, there was that exception around the pandemic because they didn't necessarily want patients coming into healthcare facilities during COVID. So they would cover home infusions, but that's not necessarily always going to be the case. And so for someone who's currently getting home infusions covered, my guess is they're not on Medicare yet.
Gotcha. Well, yeah, we're working with that. We're trying to advocate and get coverage for home infusions because our people are traveling miles and hours to get their home infusions. And
yeah, and there's some really, really strong arguments for why Medicare should cover them. I mean, it's actually less expensive and it's better for the patients. It's more helpful for people who live in rural areas, as you indicated. So there are a lot of really strong arguments for why Medicare should in fact cover those.
Are there navigators for people who can help a sick person navigate all of this? Well, I'm talking to her.
I mean, we're certainly trying to do our best to be helpful. I do realize it's a lot. Typically, I wouldn't talk to somebody about all of these things at once, but because we had people who had basically every type of insurance combination that exists on today, we wanted to give you the broadest amount of information. Depending on what you need help with, there are places to go for help. So if you're trying to figure out your health insurance options, there are those in-person assisters with the marketplace. There's a similar entity for Medicare, and they're called the State Health Insurance Assistance Programs. And they're known as SHIP programs for short, and they do exist in every single state. So if it's that piece that you're having a hard time with, yeah, there is some help. If you're trying to deal with the appeals process, there are some entities and nonprofit and for-profits that can help with the appeals process. So basically it just depends on what you need help with, and we can probably find it for you.
Yeah, I've seen that acronym for SHIP before. I never knew what it was. Now I do. Thank you.
Yeah.
I get my infusions at home by a licensed nurse. Which coverage is best for Onpattro? Well, there you go.
Yeah, so as I mentioned, I think it depends on what type of coverage you have. My guess is you aren't currently on Medicare. And so when you do go on Medicare, you may need to change that. Depending
Maybe
on
things will be changed by then. We never know, right?
Fingers crossed, right?
Okay. What are the ramifications of having a high household income? Oops, wait, I just lost that question. I got to get back again. Okay, what are the ramifications of having a high household income in the year that I sign up for my Part B? My wife is losing her job this year, end of October, and will be receiving a large severance. I'm covered under her plan now, so we'll be entering the special enrollment period for Part B. We wouldn't normally make as much income as we're making this year. Well, I think a lot of people can identify with that. What do they base the amount they charge for Part B? Is it income that year for just my income or our household income?
So I have good news for you. They actually look at your income from 2 years ago. So for people who are trying to figure out their 2021 Part B premium, Medicare or Social Security is actually looking at their 2019 income. So for you in 2022, they'll look at your 2020 income to decide what your Part B premium is going to be.
Great. Paula, did you have anything you wanted to add to that? No? Okay.
No.
Okay. Is that qualification net income or gross? I don't know.
I saw when this question popped up, and I think it is actually a question about something that Paula said, and so I can't actually speak to that.
Paula, that 5 times the poverty level.
That I'm not actually sure of. It's best to just check with the individual organization that you're looking to receive assistance from.
We're all hoping it's net, though. Okay, okay. Will the chat feature be available on the video to be watched later? You'll be able to watch this video in a couple of weeks, maybe less, when we get it up on our website and when we get it up on our YouTube channel. It usually takes a couple of weeks, but we can work on Bob to try to. He's done a lot of these now. He's pretty much an expert, so maybe it won't take him 2 weeks, right, Bob?
Well,
we hope not.
basically also Josie, I will email you the links that I sent out that I posted today. I can do that. But as far as the chat transcript, that I don't believe is made available to.
No, the chat transcript is not available on the videos. However, we could actually post the links and the information that that goes along with the video.
Great. Okay. What is the difference between getting a Medicare C plan, C for cat, versus a Medicare G for golly?
So as he clarified, he actually meant what's the difference between Medicare Part C and getting a Medigap G. And the major difference is we're talking about driving in two different lanes. Lane one is original Medicare, where you can go to any provider around the country. And this speaks to the next question about, does Mayo accept Medicare? First of all, I don't know off the top of my head, but it's a very easy thing for you to figure out by just calling Mayo and figuring out if they do in fact accept Medicare. But that's your opportunity to go to any provider around the country. And then the Medigap protects you from high out-of-pocket costs that come with Part B, that 20% coinsurance. Whereas with Part C, you have a network of providers. So if you live in Florida and you want to go to the Arizona Mayo, you probably won't be able to do that. There are very, very few Advantage plans that allow you to travel across state lines for their network. And so it's a much more limited network than you're going to get with original Medicare. But again, with Medicare Part C, it does come with an out-of-pocket maximum, so you don't have to purchase the additional plan. And so there's no one size fits all here. And so if you're trying to figure out which lane to drive in, please, please, please come to our webinar next month. We will spend a lot of time talking about that.
Thank you. And I do know all three Mayos, the Mayo Phoenix, the Mayo Jacksonville, Mayo Rochester, they all will take Medicare, but in different ways. First of all, Medicare Advantage is a no, unless I think it might be okay if you're in the state, but I think in Arizona, that's not the case. So again, just as you said, you have to contact them because some things they do take Medicare for, and some things they don't take Medicare for. So it's kind of squirrely. Okay. Can my spouse and I sign up for different Medicare optional coverages? Are there advantages to this? Is it available?
Absolutely. In fact, you don't have a choice because there's no such thing as a family Medicare plan. And that's actually a really big change for a lot of people who are used to having employer-sponsored coverage where the whole family is on one insurance policy. With Medicare, you make your choices and your spouse makes their choices. And so there's no other way about going about it. Now you may decide we both want original, we both want a plan G from this company, and we both want the same Part D plan, but that's your choice. And typically what I find is that where one spouse has a serious medical condition and the other doesn't, they might not have the same needs. And so they might not need to spend what the other person is spending on a particular Part D plan because they don't need access to the same prescription drugs. So it's very important to look at everything based on your specific needs and not collectively.
Okay, thank you. Is there an appeal process for denial of prescription coverage in the VA system?
There is, and in fact, that is something that you can find more details about on cancerfinances.org under the appeals module.
Okay. Then I have to run. You're all the best. That's sweet. Thank you. So what if you decide to move to another state and already have your plan with the state you left? What happens with that plan? Good question.
So moving out of state would be a qualifying event and would trigger a special enrollment period for you to change plans. And that is true whether you have a marketplace plan, whether you have a Medicare Advantage plan. That's one of those things where if it triggers, like if you move and you're out of the plan's network now, it triggers for you to purchase a new plan.
Okay, I think we got them all. Yeah, we do. So what we'll do, okay, I want to remind everyone that, what I will do is Paula and Monica will send me all these links. I will send out an email to all of you who have been with us today, okay? Giving you all those links again, I promise. We just ask that you fill out that survey. That's so important for us to read the results of that survey so we can help plan future events. And I know you all want to join me in thanking Monica for this wonderful, long, thank you, Monica. You must be hoarse and want a drink of water very badly. We really appreciate Paula. You're above and beyond as usual. Bob, you're great. And we can't thank all of you for attending. Monica, thanks again. This was absolutely wonderful.
Thank you so much for having me. I really appreciate it. I hope you all have a lovely rest of your weekend.
Oh, same to all of you. Take care, everyone. Bye-bye now.